see some familiar names in the participants, so that's pretty cool. And I think for a lot of you, there won't be anything so new because they're always trying to peel back newness. So we're going to talk about diagnostic tests for food allergy. And the truth is, food allergy can be hard to diagnose, as not all reactions that are temporarily associated with a food are classically allergic or things we can test for. And everyone pretty much is aware that lactose intolerance is caused by a food. Somebody who has lost their lactase enzyme can drink milk or have ice cream and have significant misery with bloating, diarrhea, and complaints that really resonate with allergic ones, but it's not caused by an allergic mechanism. And today a little boy came to clinic and he had had red dots on his face with dinner last night, but it sounds as if a salty sauce got on his face and that's what caused the dots. So the story with food allergy is always key. And then we test to confirm. So eating something and reacting is sort of the big tell that makes you think this could be allergic. But, you know, there's a panoply of reasons that somebody could have a reaction. So if the reaction sounds as if it really was allergic, somebody gets pale and passes out, that's often allergic until proven otherwise, then it makes sense to test. No test is perfect. And a dermatologist I used to work with talked about pizza kids and pad thai kids, and the pizza kid would be allergic to wheat and dairy, and the pad thai kid would be allergic to shrimp and peanuts. And the thing is, in any situation, having a pizza dinner or having a pad thai dinner, there are going to be more likely culprits and less likely culprits. And you want to find the real culprit and not identify a host of foods that are then avoided, and a child who clearly displays allergies loses tolerance to those foods. So broad testing is really not helpful a lot of the time, especially as you're navigating a course through life, since we know that maintaining tolerance in allergic kids means continuing to eat that broad diet. So we don't really want to pick up false positives. We want to identify the culprit for a reaction. And for that, in general, as most of the people who are watching now know, we do skin tests and blood tests. And with a skin prick test, a tiny amount of antigen, so the protein in a food or the protein in a pollen that causes a reaction, is placed on the skin and pushed through the surface. It doesn't go through the skin. And sometimes we already have the prick device marinating in the protein, the agent, the antigen that we're testing, and we just push that into the skin. And when we do skin testing, we're using the mast cells in the skin as a proxy for those in the gut with food allergy. And we use the mast cells in the skin as a proxy for those in the nose and the eyes for someone who walks into a room with a cat and gets a drippy nose and puffy eyes. And the mast cells are also very site specific. So mast cells floating on the surface of the eye know that they should be able to tolerate exposure to certain things. And they can be very different from the ones in the skin or the ones in the lung. So something that makes a person have a GI reaction when he or she is eating it may not be a problem when the skin is exposed, but generally it is. And we rely on the story first of all, and then these tests to help guide us making the diagnosis, to sort of confirm or refute. So here's a single prick test device, and here's a multi-test. And you can see this person has the same reaction to most of those pricks. So you really want to know what the positive and the negative look like, because if those are all the same size as the negative, this person has reactive skin, which is something to bear in mind, in as much as no test is perfect. And someone with reactive skin is going to react to every single skin prick test, and that won't be so meaningful. So when we do blood tests, either as a couple with skin prick tests or alone, because somebody's had a very scary allergic reaction and we're trying to figure out what it could be without exposing them to that thing, we're looking pretty much at IgE. And IgE is an antibody that all over the world people are making in response to worms and parasites. And that's the immunologic mechanism that gets activated when people have an allergic reaction. And so that's what makes an allergic reaction inappropriate. We should be able to tolerate a cashew. We should be able to tolerate an egg. But if we're making that kind of antibody that's designed to blast open an intestinal worm and kill it, to something we ingest, things go wrong and can be dangerous. So blood tests can get tricky because we can also see false positives, and which is a test for, say, peanut that doesn't correlate with exposure to peanut because the child had peanut butter on a bagel the morning before he went in for the test. So you again have to be careful before you test that this is a probable cause of a reaction, and then recognize that that peanut may as an aggregate of all the different proteins in the peanut be causing the reaction on the blood test report or the skin test because of a protein it shares with something in the environment. So for example, peanuts share a protein with birch pollen. And I used to take care of a cyclist who was racing in the Alps during the spring, and he ate some peanuts and his mouth got very, very itchy. And it's because he's allergic to the birch pollen that was in the air at the time. He can eat peanuts. The reaction didn't go past the oral itch in his mouth, which is what we call pollen food allergy syndrome, but it was nonetheless terrifying. So birch pollen and peanuts share a protein. And so someone with hay fever and tree pollen season can have a positive reaction to peanut. That's why sometimes a doctor will order component tests, which breaks down the peanut protein, and we can see if what's positive in the aggregate peanut test is what correlates with birch, or if it's really one of the peanut proteins that correlates with anaphylaxis. So the story again really matters, and we can break down the food test, but we don't really break down the pollen tests. And then the acid test, where you figure out if something really is the culprit in a story of an allergic reaction, is an oral challenge. And we do oral challenges here almost every day of the week. We're set up for it. And it's harder in community practice settings because they're not set up for it. It's one of the many things that they do. And it requires a room, and it requires a lot of vital signs, and it requires a dedicated staff member. And that's why sometimes it's frustrating in the community to get an oral challenge done. But it is the clincher. And here we don't do sort of one-off. It looks as if you've outgrown your peanut allergy, or it looks as if you've outgrown your dairy allergy. Almost every oral food challenge we do is part of a series that includes a placebo. And so because of what we are designed to do, which is food allergy studies, we can do food allergy oral challenges multiple times a day safely, which is really difficult outside specialized centers like this one. And so the reason to tune into a session like this is what's next, because it's clear that the skin prick tests that we use aren't perfect. And it's clear that the blood tests that we use aren't perfect, but an oral food challenge is scary. We're exposing someone to the food. It's a day basically, and it's time and effort consuming. So we want to know what the next best test is. And we're working on those here. The thing that has gotten the most press, as it's been out there the longest, is the basophil activation test. And when an internist or pediatrician orders a blood test, a CBC, a complete blood count, often he or she will order a differential. And that breaks down the different kinds of white blood cells. And we know that eosinophils are involved in allergic reactions, and that basophils are as well. Those are two different kinds of white blood cells, and they're involved in reactions to parasites and reactions to intestinal worms. So we're looking now at whether basophils and activating basophils are a reliable measure of food allergy, and can they give us a result as good as a double-blinded, placebo-controlled oral food challenge here in clinic. And basophils are not present in large numbers in most people who live in the developed Northern Hemisphere because our worlds are so sanitary. Years ago, I read a study that looked at treating children in rural Ecuador for intestinal worms to see if that increased their risk of allergy. And the inclusion criteria was whether mom pulled 6 worms out of a kid's nose during one meal. And that's the reality in places where there are really no allergies, which makes basophils and eosinophils intriguing cells to look at. So one of the things that's difficult with making the basophil activation test a standardized thing is we need new norms, because here are a host of studies that look at different foods, and you can see the numbers are not really huge. The sensitivity and the specificity varies, and we will need much deeper pools of participants to come up with numbers, so that if you or your child goes and has a basophil activation test for peanut or walnut, hazelnut, sesame, something like that, we can say, yes, this is as good as an oral challenge. We're just not there yet. And here at the center, we're collecting a ton of samples in all of our new studies to try and find something that's less invasive than a blood test, saliva, stool, things like that. And then with any new test, it's always expensive and it takes a while for things to get cheaper. And the skin test is cheaper than an oral challenge and safer. A blood test is cheaper than an oral challenge and safer, but a basophil activation test is not yet there. And again, common allergens, things like peanut, eggs, milk, those are more likely to have new tests available sooner rather than later. So we may be looking moving forward at a hybrid model of what are now conventional and standardized tests, and then newer tests for concerns of specific allergies. We're recruiting right now for food allergy tests in the Sunbeam study, Outmatch, Combine. SEAL is looking at kids with atopic dermatitis when they're very young and at risk for food allergy. And if you're allergic to shrimp, we may have rumen motif. So with these studies, we are collecting samples to help find the next great allergic diagnostic test, and would love to have you participate. I'll look at the Q&A right now. This is true. Any other questions? Let me that one. Oh, the Everly-Well test. In as much as I'm familiar with that, it seems like an IgG test, which is the Genova diagnostic test is IgG based as well. And IgG tests measure exposure. So when we're talking about COVID immunity, we're hoping for IgG to demonstrate lasting immunity to the vaccine for the virus. And Everly-Well is looking at that kind of, if I understand correctly, at that kind of antibody. So many times patients have come to me in clinic with Genova diagnostics or Everly-Well tests and point out that what they're allergic to is what they eat the most, which is what you would expect of an IgG test, because it's measuring exposure, but it doesn't measure risk of an anaphylactic reaction. Can you use donor cells for human IgE from a donor sera? In a research setting, absolutely. Oh, is 66 too old to participate? We have mostly an age 55 cutoff for most of our studies, but if you are interested, please reach out, because the 55 cutoff is in some cases mandatory because these are national studies funded by NIH and we have to follow them. And in some cases, it's sort of an arbitrary number that's designed to pull out people who might have high blood pressure and be taking those medicines. So please reach out and sign up in the registry. What's also interesting is at 66, many people, just as people in their 30s, they're hard to recruit for food allergy studies because so many have made peace with a lifestyle that means avoiding a certain kind of restaurant. But if this has been dogging you for a long time, we may have a study, so please enter the registry. Let's see the next one. The DATTA test. Well, the basophil test is a little different, but we're, as I said, we're collecting different samples and investigating all manner of sources to try to figure out how we can do a test that's the equivalent of a double-blinded, placebo-controlled oral food challenge with a little bit of blood or a little bit of saliva or some other secretion, because it would make such a difference in quality of life for people. Anything else? Yes. Oh, any update of timing when magic will start? That is the question of the moment, my friend. And I know we have a panelist who is also keen. I'm not sure. I think the going idea is May, but keep checking in because that'll be a great study when it starts. Let's see. Are the tests that look into specific proteins within an allergy helpful? So that's a good question because, as I said, somebody who's cycling through a birch forest and suddenly has an itchy mouth when eating a protein bar or a granola bar, you absolutely want to break the peanut test down, because that's how you get that person confident to go cycling in the next race. Again, the story of the reaction, that matters a lot, and what's reasonable to follow matters a lot. So if a child has an early exposure to peanut butter and has hives all over, it's not crazy for the first presentation with the allergist just to involve a peanut prick test. That's not crazy, because it's something you can follow and you want to follow it over time. If there's reason to think that in an older child, say 12 or 16, who's starting to develop environmental allergies, something else may have been going on, then breaking down that is really helpful. And I think the utility of component testing is more in peanut, just because it's better studied, than where we are with walnut at this time. That's kind of an opinion rather than based on a lot of data. And what is the placebo rate in the Outmatch study? Everybody in Outmatch for their oral food challenges has a placebo challenge. And then you can look at clinicaltrials.gov to see who is receiving placebo in stage 2, sort of a number, and in stage 3. Stage 2, some kids are getting OIT and some kids are getting placebo. And it's interesting because a little girl said to me the other day that she's sure she's getting placebo, but I'm not so sure. But I'm not sure that I fully understand the question. The allergenist test that is coming soon. Well, it's coming soon and it looks good, but I don't know enough to speak about that right now. Let me go back to the Q&A. Where do I? Lori, I've lost my cursor, which is not helpful.
Yeah, I can read out the next Q&A item, and if everyone can put their questions in the Q&A, not in the chat, that would be super helpful.
So none of the tests are conclusive. What is the IBS? Okay, so the thing with, there are some foods known to exacerbate IBS, and I think you raise a really excellent question, because we do have conclusive tests for food allergy. That's the oral challenge. And if the data that you have, say the skin prick test data, the blood test data, syncs nicely with the presentation story, you have your answer and there's no reason to turn the pages. So IBS is one of those times when a strict elimination diet makes sense, because different people with the same symptoms will have different foods that could trigger it. And it's a rough thing to do, 2 weeks of chicken and rice or 2 weeks of beef and rice, and adding foods back one at a time. But the knowledge you can gain, which is specific for any one sufferer of those horrible problems, is vast, is really life altering. And I've had patients say they've been doing it for 5 weeks or 8 weeks, and they're really sick of what they're eating. But the thing is, reminding them that they've learned so much, I think, helps them stay where they are. Because to do it again, to stop after, say, 8 weeks when you've got 16 or 20 foods back in the diet, to sort of go back is really rough, because you'll have to start from scratch again almost, if that makes sense. Okay, so thank you very much, Richard Goodman, for that. Walnut's a tough one, because we can break down the components, but what you do with that knowledge is also difficult. What else? A 6-month-old with a positive skin test for peanut, cashew, and sesame. So far, a reaction to peanut. So, I mean, that's a brilliant question, right? Because that's real life. And the reaction to peanut matters, and whether any volume of peanut can be tolerated matters, and whether the clinician you're working with is a proponent of things like spoonful one. I mean, all of those products which expose kids to small amount of antigen, that makes a difference. And what really the clincher is whether the person you're working with thinks that something is going to be helpful, because it's very hard to think that you found the answer and not get support in the real world. So I don't know. So what type of testing? I don't know that you need more testing next, because the problems with the tests that we have now, it gets back to the little kid who goes for testing the morning after having peanut butter on a bagel. It's still possible to test positive blood or skin to peanut and wheat, but we know those foods are tolerated. So the story really matters. And if somebody's had a reaction to peanuts and testing shows cashew and sesame are issues, that's a conversation to have with the clinician. Is it worth exposure to cashew or sesame? I don't know if those tests brought larger wheels than the peanut or smaller wheels. And I don't know what the positive control and the negative control looked like, because those all matter.
And I'll just read out that question so others know. What specific type of testing would you recommend next for a 6-month with a positive skin prick test for peanut, cashew, and sesame with so far a reaction to peanut?
Yeah. Okay, sorry. So the next question is there evidence that adults going back to foods will exacerbate EOE if the patient has both anaphylactic allergies and EOE? Okay, so that you're describing someone who really is in a pickle, because right now, if somebody develops signs of EOE in the national studies or within the scope of a single clinician's practice, generally the guidelines are so strongly worded that you should stop the OIT on that person, that's what happens. But there's research evidence that you can find EOE on biopsy in someone in that situation. So it would be somebody who, say, anaphylaxis to walnut and peanut and is getting walnut and peanut in an OIT setting, and then develops signs and symptoms of EOE. There's evidence that that sort of abates in time, but we're not yet at the point where it's okay to continue the EOE, the OIT treatments in anyone. It's only in these specific studies where people sign on knowing that if they exhibit EOE, it will probably continue on their oral induction of tolerance or oral immunotherapy treatments for a long time after. It's not general practice. So that question is an interesting one, because what we know now is that the EOE should abate with ongoing therapy, but that's not the practice, and that's for safety, because EOE is still a touchy, scary thing. Is there a diagnostic test in development that can be done at home? There are, I believe, saliva tests that you can do and send off to private companies, but we do not do those here because the data, the technology, what to do with the information is not there. And again, it's not always allergy data that you get back. You're getting back the results of a test, but it may not be a test that directly answers that, is this an IgE? Is this a mast cell mediated response? Okay, the next question is, my 6-year-old daughter is in maintenance for immunotherapy for peanut, cashew, walnut, hazelnut, and sesame. Will she still test positive? And how do we know when or if she can food challenge out of some or any of these foods? So if you're in maintenance for oral immunotherapy, generally that's considered lifelong. That's as far as we are now, okay? And someone came in very early in the year who had been in one of our studies 10 odd years ago, and now he's a nurse and he has a job, he has a job, he has a life, and his mother brought him in, even though 30 is his next big birthday, and he ate 30 peanuts in front of us, and she said that wasn't enough. And that's kind of an exaggerated example to prove a point. This guy, between his childhood participation in a study and his lived adult experience, seems not to be troubled by peanut allergy anymore. The question is, if he doesn't eat peanuts for a day or two, is he going to be safe? And that's got to be figured out, with close consultation to make it safe when he rechallenges himself. But eating 30 peanuts a day is such a calorie load, it's not feasible for most people. And I bring up the fact that this is a grown man with a job because he was working out a ton, because his daily input of calories to accommodate the OIT was significant. And that's why when people are in maintenance, they're usually on the doses known to be protective. So a young man finished a study here and was eating 6 grams of walnut, but one doesn't need to have 6 grams of walnut every single day to maintain tolerance or protection for that kind of significant exposure. So the question, your question, I think, has many facets. And one is for the tests, right? If she's having these maintenance foods every single day, what do her blood tests and skin tests look like? And it can take a long time for those to be less positive than they were at the beginning. And it gets back to, you can have a positive test that does not correlate with a real world reaction. So if you're actually eating a food, the test doesn't matter so much. It's your real world experience. What's different when you've completed an OIT program is that specter of allergy is always there. You're not cured of the allergy. We've just raised the threshold, the tolerance threshold, before someone has a reaction. So the jury is out because we are still in the early days of OIT, you know, for better or for worse. And so the challenge, the last part of the question, she can food challenge out of some or any of these foods. That's like the guy who came in and had 30 peanuts. If your 6-year-old daughter can have an ice cream scoop worth of peanut butter and cashew butter and walnuts and Nutella and tahini, she may have outgrown these foods. But to figure that out involves stopping and starting again. And since we still don't know, most of our studies have washout periods, and then we re-challenge, and some kids hang on to their tolerance and some people lose their tolerance. It's risky. No one can really answer that question now. All of the samples we obtain as part of our studies, we do so we can go back and look at what factors predict whether a child will do well in a specific protocol or whether it won't work. And we don't have enough data yet to answer that question. Okay. Are there any test results that would exclude someone from OIT? So many of the NIH sponsored studies exclude people who have been intubated for severe anaphylaxis within the previous 6 months, but that doesn't mean that after 8 months it doesn't work. And most of the studies that are national and have that sponsorship, there's a maximum total IgE, and some have specifics. So different studies have different inclusion and exclusion criteria. And just because someone doesn't meet the criteria for studies we're working on at any given moment doesn't mean that in 2 weeks' time, this won't be the case. The magic question, I think, is a good one, because right now the studies that are active are multi-allergen studies, but MAGIC is dairy and dairy only. And we will be opening that up soon, I hope. It's been delayed a bunch. What else?
Any other questions before we wrap up?
Is there anything? We can't see. Oh, we can't see the questions. Okay, well, I was reading those things. And please feel free to email with more questions, because we can answer those. And it's great to include a phone number when you email with questions, because then we can have a conversation and get to specific answers. Thank you for joining.
Yes, thank you everyone for attending. And again, this is our email, snpallergy@stanford.edu, if you have additional questions. Thank you so much.
Take care.